Hello, I'm Dr. Donald Jurivich. I'm a professor of geriatrics at the University of North Dakota. Today's presentation is on What Matters, Part 1. So a question arises that if you could provide better care to older adults, what would that look like? So several geriatric specialists looked at this question and came up with what we call the 4M framework. And the 4M's are what matters, medication, mind, and mobility. And each of these are to be assessed, and an action plan is to be aligned with each of the assessments. And so today we're going to focus on the first one of the 4M's, what matters. So the goals of this presentation are to assess what matters most to be able to provide patient-centered care. We'd like to look at some of the barriers that are involved with assessing what matters. And then we'd like to consider different strategies to continually gather information and revise what matters most to the older adult. So here's a case study. A 92-year-old female reports fatigue, loss of appetite, a 5-pound weight loss, and generalized body aches. Her husband died from COVID 3 months prior. The patient's daughter thinks that her mother has long COVID. When the health provider asked about her health care goals, the patient responds, "I don't know." So given this type of case, what would you think would be a better way to understand what matters to the patient? So what would you pick of these 4 options? Would you use a letter to the doctor's template by the Stanford letter? Would you screen for depression? Would you see if she's cognitively impaired? Or fourthly, would you ask the daughter's opinion over the patient's opinion, since she's the power of attorney? If you selected depression screening, that'd be correct, because in order to understand what matters to the older adult, we have to make sure that there are not intervening mood disorders and or other issues that might alter their perception of what matters most to them. So the idea of what matters is that we want to know and align a care plan with each older adult's goals, their healthcare goals, and what are their care preferences. We also want to have in the conversation end-of-life care and patient preferences for site of care. So these health outcome goals involve a variety of factors. They may be being involved with family, which is most frequent. Another one is being physically active as best possible. But there's others. Some may wish to focus on their spirituality. Some may still be working and want to focus on their occupation. So there's a number of factors that go into their healthcare goals to be able to do something better. And oftentimes we'll ask the patient, if there's one thing that we can focus on, what would that be so we could help you do, and then fill in the blank better. So care preferences are important to understand because some individuals are willing and able to do certain things and some are not so much. And so the question becomes, what about the medication regimen? Do they feel like they're taking too many pills? Do they feel like the pills are working for them? What about self-management? Can they actually take the pills, or does somebody have to set them up for them? And also care preferences. Some people don't like going to see the doctor. And then finally, screening tests. And so importantly, we always ask if an older adult would consider, for instance, cancer screening. And if they said, no, I wouldn't get cancer treatment anyway, so why bother, then that's a care preference. So there are blocks to what matters, and so they exist in the healthcare system and they exist amongst the patients and families. So what are those? One of them is that older adults can have a very rapid change in their health status. They fall, they get confused, they get debilitated. So all those changes can occur very rapidly. And then there's chronic changes that are the slow and kind of insidious aspects of Alzheimer's disease and other dementias that may interfere with identifying what matters to the older adult. A lot of times older adults may be ambivalent. There might be, as we saw in the case report, some mood disorders that might interfere with their expression of what matters to them. Also, older adults and family members may not really be aware of remaining life expectancy. This is important because as one goes beyond the average life expectancy of 78 years for men and 81 years for women, there becomes increasingly more important considerations as to what the remaining years of life might look like. Finally, the barrier towards not really wanting to talk about death, and some individuals might not want to evoke the death spirit as an impediment to understanding what matters to them. So an important concept here is this graph. You can see on the right this green dotted line, which is absolute life expectancy. I mean, that's the moment that people, live and then they die. As opposed to active life expectancy, which is about 2 to 3 years difference prior to death, that people undergo this, if you want to call it involution or frailty moment for several months to years prior to their dying. And recognizing that transition into a frail or pre-frail state prior to death is an important consideration for us as healthcare workers. Also, it's important to understand that both patients and their family members way overestimate their remaining life expectancy. And so you can see in the graph here that there's about a 3 times higher life expectancy expressed by patients over what is reality. Some of the other problems are, as providers, is that we defer to the family over the patient's wishes. And a lot of times when people are in an emergency situation, they either change their minds or they're just ignored in that emergency situation. In terms of the provider's perspective, the provider may never have asked what matters to the older adult. They may not even look at the advanced care plan until the point where they have to do a CPR or a code. And providers may often overestimate the lifespan, and so they'll suggest certain interventions that really are not going to make the remaining life years of that individual much better. So medical complexity, such as physical limitations, cognitive limitations, all graphed here in terms of what we see in the older adult population as a percentage, all can impact with asking the older adult about what matters most to them. And then also just the fact that there's so many different specialists around that you get all different kinds of answers. So one of the things that we want to look at is what are the skills that we need for applying what matters. One, as I had mentioned, is understanding function. How does an older adult function over time? And are they getting more debilitated? And if so, is that an indicator of their tracking towards the final moments of their lifespan? And again, that's important to estimate life expectancy. And there are some tables that we'll talk about that where you can use those. And then also recognizing when medical intervention is just futile. It's not going to work. It's not going to change anything. It's also important to assess decisional-making capacity because a lot of times older adults, particularly with memory loss, lose the ability to make decisions for themselves. And so then it gets deferred to their durable power of attorney. And then finally, we always want to ask older adults, what's your mission in life? What's important to you when you wake up in the morning? And if they give an I don't know answer, then that's another consideration for testing the other of the 4 M's, which is mentation, such as depression and memory loss. So just to summarize, we want to appreciate that there are differences between older adults with regard to their personal preferences and their healthcare goals. You got some people are highly activated, and some people are more laissez-faire. They just don't really want to think about it. And so there are multiple barriers to understanding what matters, and we have to find ways to navigate around those. The other point made from this presentation is that we want to be aware of the 2 to 3 year gap between active and absolute life expectancy. That helps guide us towards more understanding when to provide comfort care as opposed to acute care or regular medical interventions. And then finally, with each clinical encounter, when we cross paths with the older adult, we want to assess and manage and create an action plan for what matters most to them. Thank you for your attention, and this is part of a continuing series that we'll be talking about on what matters in the 4 M's.